Hello, ma'am. I'm Dr. Cousins, heart surgeon. Nice to meet you.
Nice to meet you.
How are you feeling today?
I'm feeling better.
I understand from your chart that you came in through the emergency department with some chest pain.
Yes.
And that you indeed did have a heart attack.
Yes.
Have you had any further chest pain?
No, I'm feeling better.
Good. I spoke with your cardiologist and we reviewed your heart catheterization. And what I like to do now is to draw you a little picture and talk to you about what we need to do to fix your heart. Is that okay?
Yes. Yes.
So your heart looks a little like this. And the biggest blood vessel in your body is what we call the aorta. And as soon as the aorta comes out of the heart, it gives what we call the right coronary artery that takes care of the right side of what we call the inferior aspect of the heart. On the other side, we have what's called the left main. And they call it the main because it gives one artery down the front and one that circles around the back. You have blockages in all three of the arteries that supply blood to your heart. And so for us to fix this, what we need to do is first have an anesthesiologist to put you to sleep. Once you're asleep, we'll open your chest right through the middle. That's not nearly as bad as you may be concerned about from a pain perspective. We'll be able to control your pain, and this incision will heal up readily. Now, once we get your chest open, under the left side of your chest, there's an artery. We're going to take that artery off the chest wall and sew it down here to bypass that blockage. In addition to that, from your left leg below the knee, we'll make an incision about this big. We'll take a piece of vein. We'll sew that vein onto the aorta here, and then we'll swing it around here, and that'll bypass and take care of that blockage. And on the other side, we'll do the same thing and get you better blood to the back side of what we call the lateral wall of the heart, okay? Now, there are some risks associated with this surgery. There's risk of infection. So before we start, we're going to give you some antibiotics to cut down on the risk of infection. There's also a risk of bleeding. Now, it's very rare that we have to use blood product, but if you were to need blood products, would that be okay?
Yes.
There's also a small risk of stroke. So sometime before the day of surgery, someone will take and do an ultrasound to take a look at the arteries that supply blood to your brain. There's also a risk of heart attack, what we call a myocardial infarction or an MI, kidney failure, or lung failure. A few people have allergies to the medications we use. That's very rare. A few people get blood clots in their leg, what's called a deep venous thrombosis or DVT. Blood clots could travel from the legs to the lungs. That's called a pulmonary embolism or PE. And then a few people who have this surgery end up needing a permanent pacemaker. All those things there, the risk is about 1%. Now, the biggest issue we typically run into after heart surgery is an irregular heart rhythm called atrial fibrillation, or AFib for short. And that happens up to 30% of the time, and no one knows what causes AFib. But what we see typically about the third day after surgery is an irregular heart rhythm where the top chambers of the heart beat out of sync with the lower chambers of the heart. We don't know exactly what causes it. Typically, it goes away on its own, but if it doesn't, then we would have to give you a blood thinner to cut down on the risk of stroke related to the irregular heart rhythm. And then there's also a risk of death. And for you, that risk is about 1%. Now, this surgery typically takes us about 4 hours to do. When we're done, we're going to put your sternum or your breastbone back together with some stainless steel wires. They'll stay there forever. Takes about 3 months to get solid like it is now. So during that time, we ask you don't lift anything heavier than about 10 pounds. Heavy lifting will cause the wires to loosen up. You'll drain fluid out of the incision, potentially get infection and need more surgery. The only other thing we ask that you don't do is don't drive for 1 month. Other than that, you'll be able to take a shower. You can climb stairs if you need to go up and down to your bedroom. We want you to do lots of walking and do whatever you feel up to as long as you protect your sternum. Now, after this surgery is over, we always push to get that breathing tube out as soon as you wake up from the anesthesia. After the breathing tube is out, then you're going to have 2 or 3 chest tubes. They're going to drain air and fluid from around your heart and lungs. Usually by the third day after surgery, we cut the sutures right at the bedside and pull the tubes out. Then we just place a small bandage. It only takes a few seconds to remove it. Now, after you are asleep, the nurses will place a catheter in your bladder to drain urine. And we try to take that catheter out immediately post-op day 1 because we need you to get up walking, so cut down on the risk of blood clots and pneumonia. And then you'll have a little bandage on your leg from where we take the vein. Now, to get out of here, which we anticipate you should be able to do about 3 days after surgery, you'll need to be steady on your feet, your pain under control, and you'll need to have a bowel movement. Once all of these things are accomplished, then we'll say that you're safely able to be discharged home. At this point, we'll answer any questions that you may have, and then we'll get you scheduled for surgery. We'll take good care of you. This is what we do all the time. We're really good at it, and we'll take good care of you and get you back home to your family about 3 or 4 days after surgery.